Medical liability system actually harms our patients and our society. Is there anyone in this audience who seriously doubts the direct relationship between the rising cesarean delivery rate and our climate of legal fear? Congress's refusal to even consider tort reform seriously last year made a mockery of health care reform, and they know it. Health care reform without liability reform is no reform at all. My second goal is building upon our collaborative community. Our OB-GYN workforce is aging, and physicians are leaving the delivery room on average 10 years earlier than previous generations. Residents in record numbers are choosing careers that do not include obstetrics right from the get-go. The 80-hour work week has resulted in a 20% decrease in resident work hours. There is recent evidence that non-resident physicians are working less hours as well. Right now, nearly half of the 3,000 counties in this country lack an OB-GYN physician, and nearly 9.5 million Americans live in these predominantly rural counties. So we have fewer fellows doing obstetrics, and the ones who are doing deliveries are working fewer hours. We are already geographically challenged and poorly deployed for optimum maternity care. In 2007, there were 302 million people living in the United States. This number is increasing by 1.1% per year, and the United States Census Bureau predicts that we will reach 440 million people by the year 2050. The generational and gender changes in our organization are already having a dramatic effect. But when we factor in the population explosion, calculate the lost manpower related to decreasing physician work hours, and consider the potential expansion of the health care insurance coverage, the need for more maternity care providers is easy to predict. Unfortunately, the number of residents that we are producing has not increased significantly since 1993. Our static pipeline and increased need forecast a severe shortage of obstetrical providers in the near future. Our hospital work has taught us that communication and teamwork are critically important. We can all learn from Mother Teresa, who said, "What I do, you cannot do, but what you do, I cannot do." The needs are great, and together we can do something wonderful. The ability to improve and extend medical care to all women and their newborns, a clear goal of health care reform, will depend in part on the quality of our collaborative efforts. We have an opportunity to be inclusive and work with all of the organizations that provide women's health care by building, promoting, and nurturing our relationships. I firmly believe that our organization's collaborative intelligence is critical to improving our teamwork on the front lines of care. With this in mind, my college issue of the year will be a joint project with the American College of Nurse Midwives. Both the college and the ACNM will ask their members to submit papers describing successful models of midwifery and obstetrical collaboration. The papers will need to be submitted jointly by obstetrical and midwifery collaborative teams. Together, we will select the winners and publish the best submissions. These models of collaborative care, best practices, if you will, may help others define relationships and improve care. The what works in collaboration could provide a framework for practice that might be crucial in our design for future maternity care. My final goal is to take a hard look at birth issues and how we can improve maternity care into the next decade and beyond. The American College of Obstetricians and Gynecologists has the ability and the responsibility to play a strong role in guiding maternity care. There is so much we can and so much we should do. I will appoint a work group to examine maternity care in the United States. This is a superb time to step back, evaluate, and make a real plan of action for the remainder of this century. We have so many genuine issues in maternity care. Let me mention several of the areas. Lack of consistent and comprehensive data about births in the United States is one area needing attention. Can you believe that in this country, with so much know-how and advanced technology, has not implemented a uniform method of recording birth statistics? Such a system would provide the data needed to evaluate practice and make clinically sound decisions in maternity care. The increasing rate of maternal deaths in this country is a significant and troubling problem. The United States maternal mortality ratio has doubled in the last 20 years, reversing years of progress. But even one woman dying in childbirth is too many. Increasing obesity, increasing maternal age, increasing cesarean deliveries, and changing population demographics all certainly play a role. Black women are almost 4 times more likely to die from pregnancy complications than white women. We cannot reverse racial disparity in maternal mortality unless we invest the dollars in meaningful research. Other countries have developed robust approaches to maternal mortality, and we should follow their lead. In the future, we will be facing a shortage of obstetrical providers. In addition, our practitioners are becoming less experienced because of the early retirement of seasoned obstetricians. We are losing our Captain Sullys in our delivery room. In my opinion, it is not acceptable to watch skilled operative vaginal delivery become extinct after 400 years of usage. We can prevent that from happening, but it will take a concerted effort. In an emergency, does anyone in our delivery room know how to apply Piper forceps to an aftercoming head? How can we increase the vaginal birth after cesarean rate in our chilling liability environment? How do we handle breech deliveries and twins? There are many questions. In the last few years, our formal focus on safety has expanded. We can now move this forward by becoming the leaders of the safety agenda. Basking in a culture of safety will save lives, prevent harm, increase goodwill, and help shield us from legal assaults. We can create safer processes, improve our communication techniques, document the care we provide more accurately. We can encourage and facilitate fetal heart monitoring credentialing. Checklists can be developed that are precise and efficient enough to be of real help clinically and to be bulletproof legally. Checklists will improve our consistency. Oxytocin monitoring checklists have already been shown to improve outcomes and reduce litigation. Airplane pilots routinely use checklists to reduce risks and improve safety. Why shouldn't we? In 2008, the cesarean delivery rate reached another record high, 32.8% of all births. There's a community not far from my home in which 45% of the newborns are delivered via an abdominal incision. Let me be very honest. This increase in cesarean delivery rate grieves me because it seems as if we are changing the culture of birth without nature's permission. While it is certainly true that a physician has a contract with an individual patient, our specialty has a covenant with our society. It is our responsibility to be